Welcome to ACOG's Video History Project. Today, we're very fortunate to have with us Dr. Steve Gabbee. Steve, thank you very much for willing to be interviewed.
Well, thanks, Ralph. I'm honored to be here.
Well, you are one of the bright stars of our specialty. Let's begin by going back with your history. Where were you born and raised?
So I was born and raised in Newark, New Jersey, until I went to high school when my family moved to a suburb, Milburn, New Jersey. Was raised in a three-family home in Newark. My grandmother developed cancer when I was about 10, lived on the first floor of the building, and every evening we'd go to care for her, and her family doctor would come in and help her, and there's no doubt in my mind that's when I decided to be a doctor, because I so appreciated his care and I saw what a difference it made for my grandmother.
Where did you go to college?
So I stayed in New Jersey. I was fortunate enough to go to Princeton University. I was there as a pre-med majoring in biology during the period 61 through 65, so we're looking forward to our 50th reunion at the end of this month. And then didn't stray too far from New Jersey, went up to New York City to go to what was then Cornell, now Weill Cornell Medical College in New York City.
And when did you decide to go into OBGYN?
That's a great question. My first rotation as a third year was in OBGYN. And I was blessed really to have the opportunity to work with people who I didn't know at the time would be leaders in our field. I knew they were special, and that was people like Jennifer Niebel, Jolie Simpson, Dick Berkowitz, Phil Mead. They were all senior residents in the training program. And then two very special junior faculty, Erwin Merkatz and John Queenan. And of course the chair was Fritz Fuchs, who was a leader in academic OBGYN. So I was blessed to work with some really outstanding people who I found very inspiring and people I wanted to be like.
It's actually a who's who in our specialty.
Yes, it was, yeah.
Okay. So where did you take your training in OB?
Well, I knew I wanted to work in the maternal complications of pregnancy. I was really interested in maternal fetal physiology. In fact, I read Jeffrey Dawes' book on fetal and placental physiology during my third year of medical school. And in my fourth year, I had an opportunity to do 6 months of research. And I wanted to go to England to work with Dr. Dawes, but there wasn't a chance to do that in his lab. He recommended I go to work with Jim Metcalf, who had been at Harvard and specialized in placental and fetal physiology and heart disease and pregnancy. And he welcomed me to his lab at the University of Oregon Health Sciences Center in Portland. And that was important for several reasons. One was because that's where I met my wife, Pat, who was a medical student at Oregon, but also because Jim had come from the Boston Lying In, then the Hospital for Women, and said, Steve, if you're going to go into OB, that's the only place for you to do your residency. So I did a year of medicine internship at New York Hospital and then went to Boston for my fellowship and my residency.
Who was head of the program there at that time?
Duncan Reed. And I remember interviewing with him. There was no match, so I had an interview with Dr. Reed, and he said, well, we have a place for you, but the way our program works, it won't open up for a couple of years. Now, you like to do research, and so what we'll do is we'll have you work with Claude Vallee in his lab, because he's interested in placental endocrinology, and we'll make sure you have a day in the clinic to work in the high-risk clinic and time in the OR, so you'll be ready for your residency training. And it turned out to be in about 2.5 years.
Well, now, why was placental physiology of interest to you? That's a unique type of interest.
Well, because the placenta did things that, if you think about it, as an organ of transport and as an organ that basically nourishes the fetus, as the fetal lung in many respects, I thought that if you understood the placenta, you could understand why pregnancies didn't go right, and you could also understand how maternal illnesses like diabetes, hypertension, could impact the placenta and then the fetus.
Well, after you finished your training, and that was a fairly long,
yes.
Then where did you go?
Well, after my years in Boston, I went to LA County Women's Hospital. It was really interesting. The maternal fetal medicine boards were just starting. And so I wrote to the head of the board, who was Ted Quilligan, and told him what I had done, told him of my interests in that point in diabetes and pregnancy. And Ted said, well, Steve, I've reviewed your background with the board, and we'll give you some credit for the work you've done in the research lab. You'll still need to do some clinical work. And by the way, we have a terrific diabetes and pregnancy program at the county. If you'd be interested, you might want to come out here and talk with us about an academic position. And that's how I wound up at LA County Women's Hospital in 1975.
What was it about diabetes that pricked your interest?
Well, that's really for me an important question, because it's determined my interest throughout my career in OBGYN. I was a third-year medical student rotating in pediatrics. It was February of 1968, and I developed all of the symptoms of diabetes: polyuria, polydipsia, weight loss, fatigue, and you know, as a medical student, you can sometimes pass those off. I was losing weight. I wasn't getting the chance to eat very much. I was drinking a lot of coffee. Maybe that's why I was urinating so much. But it just persisted. It was just not right. And so I remember on a Sunday, I was on the service on a Sunday, checking my urine, and it was 4+ for glucose. In those days, we used those colored tablets. And the next day, well, you know, I did what I think a lot of us do. I denied that it was really there. So I waited most of the next week, and I kept checking my urine, and it was positive all the time. It was positive when I got up in the morning. It was positive when I went to bed at night for glucose. So I went into student health on a Friday and told the student health leader that I thought I had diabetes. And I'll never forget this. He patted me on my head, literally, and said, "You must be studying diabetes this week." No, I said, "I think this is the real thing." So he said, "Well, we'll draw your blood and check your urine, come back in an hour," which I did. And he said, "Oh my gosh, your glucose was over 230, you have diabetes." And then something that I think unfortunately happens to a lot of us as physicians, I was a medical student, he assumed that I knew a lot about diabetes, which I didn't. He also assumed, because I was 23, that I had type 2 diabetes, because I wasn't an adolescent when you get what we then call juvenile diabetes. So he started me on oral meds, and it was clear in about a week or so that wasn't going to work. So I started on insulin. And you know, I've been on insulin at this point for over 47 years. So during my internship in medicine, people assumed I knew a lot about diabetes, and they kept admitting patients to my service who had diabetes. To be honest, it's the last thing I wanted to see. I didn't want to see patients with all the complications of diabetes, but that happened. So I got up to Boston in January of '75 to start my fellowship and my residency. And I'd been given the name of a famous endocrinologist at one of the leading hospitals in Boston. I won't give the name of the physician or the name of the hospital.
I bet you I could guess.
I bet you can. And I called him up, and I said, "I'm Steve Gabbee, and I have then juvenile diabetes, and I'm going to be here for my training for the next 5 to 7 years. And Dr. So-and-so in New York highly recommended you, and I hope you can care for me." And he said, I hope I don't offend anyone, patients with juvenile diabetes are a pain in the ass. And I limit the number in my practice. Now you're up there at the lying-in hospital, and Dr. White is there. She takes care of the pregnant women with diabetes. Maybe she'll take care of you too. I remember it like it was yesterday. So I saw Dr. White. I didn't know Dr. Priscilla White. I didn't know who she was or what she had done. But I saw her in the hall one day. She was a small, gray-haired lady. Then she was 70. And I introduced myself to her and told her the same story that I had told the famous endocrinologist. And she said, "Stephen," and she always called me by my first name. I just always remember that. "Stephen, I'd be honored to care for you. Why don't you come up to the Joslin and we'll talk?" And so I did. So she became my physician. She became my mentor. My research in the lab, I changed from the endocrine metabolism in the placenta to carbohydrate metabolism. I began to see patients with her in the clinic, and of course she had really started the first diabetes and pregnancy programs. She had initiated team care, so I saw patients with her, with Luke Gillespie, who was the obstetrician for the Joslin. What a great clinician he was. And I would round with Luke on the patients in the hospital and go to the clinic and work with Dr. White. And you know, I was really blessed to meet her. All the residents worked with Dr. White and Dr. Gillespie at some point, but I had a relationship that went on for years, and I continued to call her about my care for many years until she died when she was 90.
She was a remarkable lady.
She was. You know, she had gone to Radcliffe and was turned down by the Harvard Med School because she was a woman. She was turned down for residency at Harvard because she was a woman. But Ellie Joslin had met her as a student or a resident, was very impressed with her, and hired her in 1922. If you think about it, you know, insulin was first administered in January of 1922 in Toronto. So she was there early on when insulin became available to keep patients alive. So she had seen it all. And she had, you know, in 1928, I think, she realized and stated that glucose control was key to the well-being of the fetus. And we know that. That was an important lesson for all of us. And she knew that back in 1928. And like Ellie Joslin, she advocated very strict control, as best we could do it then, because we didn't have meters or the new insulins or insulin pumps or any of the advances we enjoy today. And she really described how to care for patients with diabetes. And you know, there isn't a day I go to clinic that I don't remember something that Dr. White or Dr. Gillespie taught me.
Well, when you left Harvard and left Boston, where did you go next?
I went to LA County and took up Ted Quilligan's offer, and what a fortunate decision that was, because I got to work with George Messman, in the diabetes and pregnancy clinic. He was a great clinician, a great endocrinologist. And of course, Ted Quilligan was there, Roger Freeman, Ed Hahn, Dick Paul. I mean, a who's who of maternal fetal medicine. And George Messman also became my physician, and he said something to me that I've repeated many times to the young people with diabetes that I talk with about diabetes and living with diabetes. And George said to me one day, he said, you know, Steve, I want you to think of diabetes as a condition and not a disease. Just a simple difference in words, a condition. He said, because you will always get good medical care, because you will never smoke, because you will exercise, and because you'll eat a good diet, I bet you will do better than most of your friends who don't have diabetes. That was, you know, 40 years ago. And I have to say, I think George was right. You know, he was not, I don't think he was, I think he was telling me what I needed to do as well as advising me on what I needed to do. And again, I've worked with George over the years. We've done research together, and I still am very close to George.
And where did you go after USC?
I went to Denver. I was very interested in working with Ed Makowski, Giacomo Meschia, Fred Battaglia, and their sheep model that they were investigating fetal metabolism, carbohydrate metabolism, but not in vitro as I had been doing it with little placental explant studies. They were actually using the sheep fetus to study why the fetus of the diabetic mother was more likely to die in utero. And they were looking at the impact of hyperinsulinemia on fetal metabolism. So that was really a terrific opportunity. There weren't many labs that were equipped to do fetal research, and they had a terrific group. And again, working with the three senior leaders, working with Bill Kluhl, Waddy Bowes, so many of the outstanding leaders there. They also had a great neonatology program led by Mike Simmons that was really pioneering maternal transports and exploring the limits of viability for neonatal survival. I learned a lot there.
And then you moved on?
Went to Penn. And I moved several times early in my career, in part for professional reasons and in part for family reasons, and went to Philadelphia to be the head of the Division of Maternal Fetal Medicine. You know, thinking back on it, I wasn't a regular faculty person very long. I mean, I started at LA County in January of '75, and by late '78 went to Penn to become a division director. And you know, there were things that I realized I would not be able to do. I wouldn't be able to spend a lot of time in the lab as I have been doing in Colorado. I'd be doing more administration. But I thought working at Penn with Mike Minuti, working with Luigi, and the team there was a great opportunity. And Penn was a terrific medical school and medical center. So I went there when the division consisted of me, Mike Minuti, and Arnie Cohen, who was a fellow and had been a fellow medical student with me at Cornell, 3 people, and I was there 9 years, a terrific 9 years.
That's interesting that you were with Arnie.
Worked with Arnie, and you know, another fortunate event was that Mark Landon, who was there as a resident, and Mark and I met, became very close. Mark had a passion for diabetes and pregnancy, as I did, became a fellow with us, junior faculty, and when I left Penn to take on the chair of OBGYN at Ohio State, Mark was the first faculty member I recruited, and of course now he's the chair of the department there. And that's been great to see his successes over the years.
I think I first met you when you went to Ohio State.
Yeah, yeah. When Fred Zuspin, I mean, if you think about it, how blessed I was to work with Ted Quilligan as the department chair when I began my career, and then to follow Fred Zuspin at Ohio State. And I'll never forget, I got there and Fred said, "Okay, Steve, it's your department. I'm moving down the hall. If you need any help, you know where I am." And he was a great mentor and, of course, another outstanding leader in our field.
Yes, he was.
Yeah.
And then you moved on, and he moved into academia, higher academia.
Higher academia as a chair at Ohio State for 9 years, and really enjoyed it. And went to the University of Washington after 9 years. You know, Bob Petersdorf, who is the president of the AAMC, said that a chair's term should be about 9 or 10 years. He said, you know, the chair goes through 3 phases: hoping for about 3 years, coping for about 3 years, and moping for about 3 years. And he said, after you've been a chair for 9 or 10 years, it's probably a good time to let someone else have a chance. And Larry Copeland succeeded me and did a great job. And we went to the University of Washington, another outstanding medical school, medical center. And we did that in part because my wife Pat's family, a lot of our family, were from the Pacific Northwest. Her folks have been ranchers in Oregon since the 1880s. And again, very blessed to work with Mort Stenshaver, great leader in the college and great mentor for me when I was the chair there, and so many other outstanding maternal fetal people, Tom Benedetti, Tom Easterling, Zane Brown. We all worked together, great diabetes program. And as the only medical school in the state of Washington, you know, we had a real responsibility to train students to go out and practice in the state for primary care, OBGYN. And I think when we went to Seattle, we thought, well, maybe that'll be our last move. We're closer to home, closer to family, and this is probably where we'll settle.
But it didn't.
It didn't work out that way. And what happened there was that Gordon Gee, who had been the president of Ohio State when I was first there as a chair, became the chancellor, excuse me, or the president at Vanderbilt. And they were looking for a dean for the School of Medicine. And Gordon asked if I'd consider being a candidate, and I said sure, and I went there to interview, and to be honest was very surprised, was selected for that job. There was a very strong internal candidate, and during my interview process people said, well, you're an OBGYN. Deans don't usually come from your specialty. But I said, you know, on the other hand, we're primary care physicians, we're surgeons, we take care of patients across their lifespan. We work with pediatricians and internists. We really have a great view of the overview of academic medicine. So I got to go there and be the dean at Vanderbilt, which was an incredible honor and opportunity that I would never, ever have imagined I would have done as someone when I started my career.
How long were you at Vanderbilt?
I was at Vanderbilt for 7 years. President Gee, or then Chancellor Gee, did something that surprised everyone. He went back to Ohio State. And he had been the president there once, and he went back for what they said was Gee 2. Now his daughter Rebecca, who Pat and I have helped mentor over the years, Rebecca went to the same med school I did, Cornell, and of course went into OBGYN and trained at Harvard as well. Really encouraged him to go back to Ohio State because she felt it was where he had such a strong base of support and friends. So he went back to Ohio State, and as it would happen to be, the CEO of the medical center had stepped down, and so I was asked to look at that position. So I went from a chair to a dean, and then to the CEO of the medical center, which, you know, was a big, big job. It was, 6 hospitals, 17,000 employees, about a $2.5 billion budget, med school with 800 students, over 800 residents. It was a huge job. Well, I was fortunate. I had been there once before. I had a lot of friends. I knew the town. I knew a lot of the people who were leaders in the community. That helped. Of course, I had worked with Gordon Gee, so I knew him well, and we had a great working relationship. And so I took on that job and worked very hard for the now 7 years until I stepped down just recently.
What are your plans for the future?
Well, people come up to me in the hall and they say, what are you going to do now that you've retired? Well, I haven't retired. I'm spending most of a day in the clinic now working with our residents. I have several medical student teaching responsibilities. I'm working on the 7th edition of our textbook, Obstetrics, Normal and Problem Pregnancies. Interestingly enough, we started that book 35 years ago, we being Jennifer Niebel, Jolie Simpson, and I. So those 2 folks who influenced my career as a medical student, we started the book, and we have 6 other editors who will take it on because this is going to be our last edition. I work with my wife Pat on an infant mortality task force because Columbus unfortunately has a very high infant mortality for a city its size, as does Ohio as a state. And Pat has a wonderful organization she has started called Moms to Be that works with moms at risk in some of our areas of highest infant mortality in the city. I'm working with our Near East Side community where we have a community hospital, a very impoverished area, limited access to services, and an area that needs a lot of help, and we're working there to improve housing and health care, and also to help the schools develop what we're calling a Health Sciences Academy through 5 grammar schools, a middle school and a high school, to introduce kids to careers in the health sciences with the 7 health sciences we have at Ohio State. And I'm working in another area that's been of great interest to me, and that is my concerns about burnout in medicine, in physicians and in academic medicine. And I'm working with a group we have that mentors and supports our faculty. So I'm keeping pretty busy.
Sound like you retired at all.
No, not at all.
Well, let me ask you a couple of questions. What, of all these experiences, what's the one thing that stands out most in your mind?
I think there are 2, if I could say there are 2. One is the hundreds and hundreds of women with diabetes and pregnancy I've cared for over the years that I still hear from, in part because our work helped them to have a healthy baby in most cases, and also because they inspired me, and I learned a lot from them. It's a lot more difficult to go through pregnancy as a woman with diabetes and be thinking about your developing fetus and the role you're playing in its health or not health. And so I found that very inspirational. And the other thing is, as a residency program director, which I was for 14 years as a chair, and as a department chair and as a dean, you know, the thousands of medical students that trained during my leadership who will go on for decades to continue to deliver outstanding patient care, and really that impact for the years ahead, I think it's just so meaningful.
You've been around a long time in our specialty. You've been one of the leaders in our specialty. If a young medical student comes up to you today and says, I'm thinking about a career in OBGYN, how would you advise them?
Well, I would tell them that it's the most rewarding specialty they could choose, because it is an opportunity to know your patients not only over the course of a pregnancy, but over the course of a lifetime. Not only to know your patients, but their entire families. To develop relationships that go on for decades. I still get cards and letters at Christmas time, holiday time, with pictures of families and thank yous and notes from patients I've cared for. So it's a very meaningful relationship. And it's a specialty that allows you to practice primary care, to practice in very high technology specialty areas, to be a surgeon. I mean, there's limitless opportunities in OBGYN. I think we've come very far in understanding the need to balance work and life, family and work, so that today I think that the practices are much better organized, much better scheduled, if you will, so that OBGYNs can have a better rounded life than perhaps we did earlier on in the specialty.
Where do you see the future of our specialty going?
I think with the emphasis on primary care, with the need in the community for us to really lead the way in women's health care, I think what we do is going to become more and more important, with the recognition that we play such an important role in childbirth and infant mortality. That's just critically important for our communities. I think we're going to continue to grow and be better respected for the important work we do.
As we are closing up this interview, what advice do you have for young OBGYNs starting out today?
Yeah. Well, this goes back to my concerns about burnout. And what we realized is that the risk of burnout is greatest when you're starting out. It's the new medical student, the new resident, the new practitioner. After you've been in the practice for a while, you figure out how things work and you develop a support structure. And so I would tell them, be very thoughtful as you begin, have realistic expectations, develop your mentoring relationships and your support relationships, and make absolutely sure that you set aside enough time for your family and for your friends and for those activities that keep you a whole person.
I want to ask you one question at the end as we're ending up here.
Sure.
What do you think about that new research that ties diabetes in pregnancy to autism?
Well, I saw that in JAMA, and it's interesting. They found that the risk was associated with gestational diabetes diagnosed before 26 weeks gestation, really a mean of 16 weeks. Mm-hmm. And I think this is just another example, if this holds out, of the impact of fetal development on disease later in life. You know, it's not too far to think that, yes, hyperglycemia could influence brain development and lead to autism. I think this is the first large study that's been done on this. I think we need a lot more information, but I don't think it's too far-fetched to imagine that there could be an association.
I think we're finding a lot more impact of diabetes than we ever anticipated.
Yes.
When I was in medical school, it was one lecture during the clerkship,
Yes.
and usually the junior faculty had to give it.
No, you're absolutely right, and I think this is aligned with the American Diabetes Association and the American College, who are emphasizing that when we see women who are at risk for diabetes in pregnancy, who haven't been identified, to test them as early in pregnancy as we can so that we can treat them and hopefully avoid some of these problems.
I think that's excellent advice. And with that, we will end the interview. And I really do appreciate you sharing with you. I hardly realized that the time had gone.
Me too.
You had a very fascinating career, and you've done great things, and you are well respected in our specialty. You know that.
Well, thank you, Ralph, and your friendship over the years has meant a lot.
You.
So thank you.